Thank you for joining us for today's final talk. I'm Heather James, Conference Producer at Technology Networks, and I'm pleased to introduce Dr. Craig Eagle presenting the much anticipated talk on diagnostic testing in the role of precision oncology. Dr. Craig Eagle currently serves as Guardant Health's Chief Medical Officer. Prior to joining Guardant Health, Craig attended medical school at the University of New South Wales in Sydney, Australia, and received his general internist training at the Royal North Shore Hospital in Sydney. A warm welcome to you, Craig. Following the presentation, we will have a Q&A session, and we welcome any questions that you may have. Please ask questions using the Q&A system to the right-hand side of the video player. Without further delay, I will now hand over to Craig to begin his presentation.
Thank you, and I would like to thank the organisers for inviting me to present this exciting topic, and that's diagnostic testing in personalised medicine. There's a few things I'd just like to cover off first up, and that is personalised medicine and precision medicine are often used interchangeably, and for my talk, I will consider them one and the same thing. In addition, when people think about personalised medicine, they often think about genetics and the makeup of DNA and genomics. And my focus here will be on the personalised medicine and the diagnostic testing using molecular basis and cellular function as the personalised approach. And of course, we have to recognise cellular function is often an impact of both genetics, the expression of the genetics, and the environment. And importantly, the cellular functional molecular state, I'm going to focus for the examples of my talk on personalised medicine, particularly on cancer and solid malignancies. So this is what I'd like to cover through the talk. So I'll do a brief summary of what the current state is, and in particular, how we see disease through DNA and somatic mutations, and then move on to some of the barriers to personalised medicine and diagnostic testing, and then what we're looking forward to overcome those barriers and how we're trying to enhance the personalised medicine approach. And then ultimately take a brief moment to look into the future of testing and the future of personalised medicine. So first and foremost, one can think of the current state of molecular diagnostic testing through measurement of DNA alterations. And of course, we've got the starting point of germline analysis, where this is a one-time point over a lifetime. And we mustn't forget germline people often think about as a mutation that increases the risk of a disease. But similarly, we can think about germline mutation in the pharmacogenomic sense as well, and the way drugs are handled in the body and processed in the body. And this is personalized in terms of grouping people with similar genetic makeup for a very limited few people that can be affected by these germline mutations. And what it does allow is it allows this preventative intervention in that group. If we move now to cancers as we focus today, one of the areas that you have to think about is it's a focus of a mutation or DNA mutation. And so for the majority of people, this means taking a sample of that cancer, and certainly for solid malignancies, you have to have an invasive tissue biopsy, which has all the repercussions of side effects and impact on the patient's well-being. And potentially with the polyclonal state of solid tumors, measuring the genetic makeup can sometimes lead to sampling error and potentially to misgrouping of people inside the personalized medicine. Finally, today, as occurred over the last about 10 to 15 years, has been an increased focus on looking at non-tissue-based somatic testing in cancer. We know in hematology that in particular, the blood where the cancer resides in most cases, leukemias, lymphomas, etc., there's been ongoing genetic testing from the blood for some time. However, more recently, in the last 10 to 15 years, there's been increasing ability to assess the cancer from different body fluids, whether it be the blood itself with liquid biopsies, which are certainly becoming more and more mainstream in diagnostic testing and personalized medicine. But ultimately, people are looking into other forms of body fluid, whether it be sputum, urine, or even CSF. And the beauty about the access of these types of testing is it's less invasive. You don't have that tissue biopsy. It's repeatable, and it captures the entire somatic state or a mixture and doesn't have the issue of biopsy polyclonal disease. It also enables tracking molecularly. So for the first time, we can actually repeat the test over the time of the patient's journey. However, the test itself is often limited in these body fluids by the dynamics of DNA or the DNA excretion from tumors into the bloodstream or into the sputum or the urine or the CSF. So this is really the state for personalized medicine diagnostic testing today when we think about how do we assess that molecular basis and the cellular state of a patient. So now as we think about the types of testing that are available today for personalized medicine, we need to think about what are the limitations and barriers to that particular type of testing. So when we think about tissue biopsy in solid cancers, I've already mentioned that it's a biopsy potentially that may have sampling error. And in particular, if you start to look at cross solid tumors, whether it be multiple different types of cancer or even an example like lung cancer on the right, you can see that the tissue, when it's sampled, is actually used for multiple purposes. First and foremost is to diagnose the person with cancer. And this often involves consuming the tissue and using it for that testing initially. This results often in a lack of tissue that's available for a patient to undergo genomic or genotype testing or somatic mutation testing. And you can see here the various numbers in multiple different cancers can range from 70% down to 23% of people do not have enough tissue available for testing. And again, similarly in lung cancer with different stages and different settings, you can see the range here of tissue not being available for genomic testing. So this becomes a challenge when you're thinking about diagnostic and personalized medicine. Another barrier to the current standard is our understanding of the actual changes that occur over time. And you can see here that this was a study looking at osimertinib in second-line in lung cancer as an example of the challenge we face when we're limited to somatic DNA detection. So these are patients that have been randomized in a trial and they've been put on a second-line drug, osimertinib. As that patient's been treated, assessment of the mechanism of resistance to osimertinib was looked at in the today setting of somatic mutations. And you can see here that the vast majority have no known mechanism when you are looking and limited to DNA mutations. On the left, you can see here the current resistant mutations to osimertinib are listed out and very typically look at different forms of either mutations or amplifications or cell cycle gene alterations. Yet with that, as I say, 60% still remain unknown. So if we are looking at diagnostics in the personalized medicine space, 60% of people, we're not getting there with the current technology and approach. The other piece to consider is the ease of following a person with their journey of cancer care. So here I've depicted a slide that shows on the left, you can start somebody with screening and early disease detection. Then if they're diagnosed at that early stage of cancer, they really can have some sort of treatment that potentially can control the cancer for a projected period of time, potentially even cure them in the middle of the slide. And ultimately for those people that are diagnosed with advanced cancer, they can have therapy selection, which goes through different lines of therapy as the disease comes and goes. The bubbles represent the bulk of the disease, and the different colors represent the DNA or genetic makeup. And one of the important things about personalized medicine when you're going through the journey of cancer, as anybody who has been through this journey knows, you have the key questions down the bottom, which are, do I have a cancer at the beginning? Do I still have the cancer? Am I responding to therapy? Has my cancer returned? And what kind of therapy is best for me? Now, if we think about those questions, the current barrier to testing and personalized medicine is that tissue biopsy occurs at cancer detection, highlighted with a circle, or it occurs at recurrence. And then after that, the treatment is then judged by imaging and various CAT scans, which doesn't depict the molecular or cellular state of personalized medicine. So again, this is where a platform that enables repeated molecular testing in a broader array to catch that 60% of resistant disease would be very advantageous as we move forward into creating a more personalized medicine state. So really what's going on? Really, we can see here on the left that you talk about genomic profiling. That's where we are today. And as I mentioned, genomic profiling has not delivered the full promise of solving the personalized treatment and diagnostics for cancer. So that really leads to the biggest unknown, which is how is that genomic alterations, how do they work and create a cellular state and a molecular state? And this leads to epigenomic profiling. Genomics really is blind to cell type and function, but once you overlay genomic testing with epigenomic profiling, you start to get a more complete picture of what is going on in the person that you're testing. If we can couple that with monitoring the disease over the length of that disease progression and time change, then we now have a much better diagnostic option for personalized medicine. So that brings me to the next section of my talk, which is really how do we overcome these barriers? And let me share with you some of the exciting data that's been coming out around mixing epigenomics and genomics. So first and foremost, at Guardant, we're working towards this vision of providing a more complete diagnostic approach. So something we've called the smart liquid biopsy, where it unlocks both epigenomic and genomic state. This is run on the one blood sample, which enables us to repeat the test through simple blood phlebotomy testing. And you can see here on the left that once you collect the blood, it is labeled both for a sequencing of the genome and also for the methylation-based encoding. The barcodes are attached to the various fragments of cell-free DNA, and the sequencing of the genome is done as per usual genomic testing. As the decoding of the actual genome occurs, there is also an opportunity not just to look for the decoding, but then if we move to the middle, where we have extraction, we can actually go back to the barcodes and start to look at the methylation state in each region and actually come up with not just the genomic changes, but also the epigenetic changes based on the methylation state. And so you can see down the bottom that you would ultimately end up with a cell type and disease-specific fingerprint. Once you couple that with all the data that is being collected, both from the methylome and also from the genomic state, you can analyze this through various computing technology to quantify and characterize the cancer state. So here's an example of the type of ability that epigenomic information can bring. So with epigenomics, we're able to look at thousands of differentially methylated regions from, say, for example, cancer cells versus normal cells. And so here's an example of colorectal cancer and healthy. And you can see here that when you plot the differentially methylated regions, you can see here that the blue coloring on the heat map is very clear when somebody has a colorectal cancer state versus a healthy state. And so this now really starts to open up the ability to personalize medicine from a blood test in a way that we haven't had before. And so ultimately, what you end up with is a key determinant of the epigenomic state can be methylation. And so you can see in the top part of this diagram, you can get different cells based on either genetic information, so blood cell or liver cell, where methylating an unmethylated gene A, for example, becomes functional in different cell types. When you start to put this over that 1,000 different epigenomic points, as I showed in the colorectal cancer slide previously, you can start to see that you can put together a map, a binary map, if you like, of all the different cell types. And not only that, but also the cell types and whether they are a unique fingerprint of a disease, in the case of the colorectal cancer, or whether they're actually a unique cell type that is performing in particular cases, for example, in the immune system. So this now starts to provide a much broader picture of that diagnostic personalized medicine in oncology. What are some examples? Is this possible both with the blood test and with tissue? So here's an example when you start to look at methylation and you look at tissue of origin. You can see in the middle panel here on the heat map that there was different tissues that were assessed through methylation and unique fingerprints. You can see there's bladder, colon, breast, lung all highlighted here. If you move to the blood on the right, you can see by performing methylation on cell-free DNA fragments, you can actually start to pick up the DNA that's coming from the same tissues, whether it be breast, bladder, colon, or lung. So now you can imagine that you start to couple this information with the ability to take a simple blood test and start to then decide what is the tissue of origin and where is the cancer coming from. Another example of how methylation can encode cancer subtypes. Here is an example with breast cancer, and you can see here In the middle on the tissue side, you can see hormone receptor negative and hormone receptor positive. That's the HR negative, HR positive. And when you start to look at the blood on the right, you can again see that you can start to distinguish between different cancer subtypes, whether it be hormone receptor positive, HER2 positive, or hormone receptor negative, HER2 negative. So one can start to imagine that you can start to now personalize medicine based on the molecular state from a simple blood test. And this really starts to open up the opportunity for sending treatments to the right patient. But on top of that, it allows a serial monitoring and blood test to continue. Here's another example, particularly related to some of the germline mutations. And this is an interesting example of how genomics asks the question, but epigenomics can extend the question. So we know that when there's a BRCA1 mutation, particularly in triple negative breast cancer, there's an opportunity to treat them with a specific therapy, PARP inhibitors. If we look at the germline mutation here in this particular example, you can see that the BRCA1 mutation covers the bottom heat map with the green on top. Highlighted in the box, though, interestingly, when you marry it with epigenomic expression, you can get a relatively BRCA promoter methylated state. This asks the question then, if we're talking about diagnostic for personalized medicine, when we look at this particular report, 24% of triple negative patients had associated promoter methylation, and i.e. a BRCA negative state. The question now becomes, do these people, as you group them together, how do they respond to PARP inhibitors like the germline mutation? Now, of course, this brings up the issue as you're looking at starting to personalize some of these patients. You can now group them and start to understand their disease and their outcomes by more identifying and personalizing their therapy and their diagnosis. Colorectal cancer, similarly, when you start to look at MLH1, you can see here there's a similar group of patients that have MLH1 promoter methylation, which is similar to being MSI high patients. So again, the question becomes, as we look at the data and the studies to date for treatment of MLH1 or MSI high patients, it has not incorporated patients with the promoter methylation or the functional state of MLH1. This also opens up the question, would these patients be eligible and have benefit from immuno-oncology therapies as an option similar to their somatic mutation MLH1 colleagues? And we can go one step further and we start to think about lung cancer and the different histology types of lung cancer. As we start to think about epigenomic states, we can start to distinguish between small cell lung cancer from non-small cell lung cancer. Here on the left, you can see in the top right, the blue is small cell lung cancer and the bottom right is non-small cell lung cancer. And then similarly on the right panel, you can see the differentiation, not just between small cell and non-small cell, but within non-small cell, you can start to use methylation to distinguish between adenocarcinoma and squamous cell. And really this becomes an opportunity again through various simple blood testing and DNA opportunities and methylation epigenomic opportunities combined to really start to distinguish for the first time the molecular and cellular state from a repeatable, simple blood test. Of course, one has to ask, these things are all done already with diagnostics, particularly around histology. And really what I'm demonstrating here is that by using epigenetics, we are looking at the programming and the interpretation of genomics within the body and within the disease. And remember that 60% in lung cancer that we don't have clear definition of why they're resisting or failing therapy. When we look at the genomic, we get about 40%, as I demonstrated, with EGFR, MET amplification, and so forth. What we are learning, though, through this epigenetic reprogramming is cancers can have a clustering and different type and phenotype based on the epigenomics. So in the top left, you can see here with prostate cancer, there was a study that demonstrated that when you look at DNA methylation, you can start to cluster prostate cancer into different types and phenotypes and group people depending on how they respond. And some of the phenotypes, for example, are neuroendocrine transformation. Others remain adenocarcinoma. Some states prefer to not secrete PSA. So we start to now open up and start to look beyond the DNA and beyond the genomics and look into the epigenomics. We start to learn a lot more about how prostate cancer is moving. Similarly, it was reported in this article that if you look at lung cancer, there's transformation of non-small cell lung cancer into small cell lung cancer. And often that resistant mechanism becomes a cancer transformation and plasticity rather than a straight genomic mutation. And you can see down the bottom, when you look at lung cancer adenocarcinoma, it can transition into small cell lung carcinoma in the orange at the top left of the graph. And in the red, of course, you have small cell lung cancer. And you can see, excuse me, you can see the difference between the two here, but nevertheless, it's interesting how there's an overlap between the two cases. And finally, it was suggested when you start to look on the right, when you look at transitional plasticity, that you start to have the emerging hallmarks of characteristics that not only are non-mutational epigenetic reprogramming, that unlocks phenotypic plasticity that we're not picking up today in the current field of somatic and germline DNA mutations. And this ultimately has other impacts across the environment, whether it be senescence of the cells or ultimately other environmental impacts like the polymorphic microbiomes or the immune system or the microenvironment. So as we're starting to learn more and more about the different diagnostic tests, epigenomic becomes a key learning. Finally, the other interesting side of this, as I mentioned, we've focused on the cancer itself and the disease and the ability of genomics to complement and add to epigenomics. Another interesting area on genomic and epigenomic interactions starts to become around toxicity. And this was a recent study published that when you start to look at patients with breast cancer who receive trastuzumab and anthracyclines, they're at risk of cardiac toxicity and cardiac events. And interestingly, if you look at genomics, the genomics doesn't change from the original breast cancer. However, when you look at epigenetics, you start to discover an ability to pick and determine. If you look in the left on the heat map, you can see breast cancer people with positive heart failure, and you see the epigenetic profile is different from those who are negative for heart failure. And it turns out that this prediction on methylation signature for cardiac toxicity is a very strong signal when you look at the ROC curve on the right. And this is all achieved from a simple blood test analyzing the molecular and cellular state. So this can add significantly to the personalized medicine approach through diagnostic testing. Finally, one thing to keep in mind is as we're looking at the various diagnostic testing, another approach is to look at the molecular expression of the tumor. So here, for example, when you think about genomic testing and epigenomic testing, you can see here that monitoring the disease through changes over time becomes another advantage for personalized medicine. And when you look at genomics, you can see in the middle graph that you can get a change in the tumor fraction or the cell-free DNA fraction that's circulating. And that change can have no difference when you look at the confidence intervals. They overlap in the dotted blue line. When you add in far more understanding of the disease state, the cell-free DNA, the epigenomics on top of the genomics, you can actually become more confident, as demonstrated here with the smaller confidence intervals, that change is a real change and not just a variation of biopsy. So this enables us to get greater precision around trends in someone's molecular state and the overall disease burden. And here's an example of monitoring through circulating DNA on the therapeutic response prior to radiographic response. And this is just an example, again, somebody with lung cancer who had progressive disease after stopping erlotinib therapy, a therapy used for lung cancer, due to toxicity. And you can see here that when you look at the blue line suggests that they start treating the patient with afatinib after toxicity of erlotinib. But you can see here on the blue line, EGFR with the mutation L858R actually started to increase in the blood. Down the bottom, you can see that once you start to look at the scans, You can see at the bottom, there's progressive disease on the left. This was after erlotinib therapy was stopped because of toxicity. Afatinib was started and they had a partial response. Ultimately, you can see that PD at month 8 was progressive disease, yet you can see that the patient continued to have increasing amounts of cell-free DNA up to 3 to 4 months before the scan showed any change. This resulted in a switch of progressive disease to osimertinib, and you can see at 10 months, the patient went into partial remission. Importantly, the molecular state and the personalized approach actually can be picked before the scans were actually showing any demonstration of progression. And so this enables a different personalized approach to treatment monitoring, and ultimately disease monitoring. It's also interesting to note that if you look at the green dotted line down the bottom, you can see that not only was it progressing on the EGFR L858R, but also there was a resistant clone that was growing as well with a mutation T790M. And so again, with molecular characterization and diagnostic testing, we're able to parse out the different measures of disease progression and even be able to pick it up before traditional CAT scans are able to identify it. And this enables us now to start to look at broader based therapies when you start to think about molecular response. So here in this study, patients underwent a molecular response test and actually showed that for those people that were on pembrolizumab-based therapy or immuno-oncology therapy, that if you had a molecular response and with a reduction of more than 50% from baseline of the cell-free DNA variants, you can see here that the outcome was actually very different. So the molecular responders had a better outcome on progression-free survival and overall survival versus those that had persistent disease. So again, how does this enable us to personalize immune therapy? And one can consider the molecular non-responders could be a group that could be focused on for additional therapy on top of their standard of care for immuno-oncology. Similarly, if you look at the actual association between a more traditional CAT scan RECIST response and durable clinical benefit in non-small cell lung cancer treated with pembrolizumab, you can see here on the left that when you look at molecular response, you can see that the difference between CR and PR, complete response or partial response versus stable disease versus progressive disease, you can see there's a steady climb of molecular response, which shows a good correlation between CAT scan imaging responses to immunotherapy as to the molecular response. And similarly, if you start to look at the actual durable clinical benefit on the right versus the non-durable clinical benefit, you can very quickly see from a diagnostic test, you can start to pick out those that are going to have a durable response versus not a durable response. Again, thinking about personalized medicine, this enables more precision around the actual diagnostics and treatment of those patients. Finally, it really comes down to that when we think about personalized medicine and the diagnostic approach, we need a test that is able to follow the patient's journey with their disease, in this case, cancer, and also not just assess the genome, but assess how the genome is being used through epigenomics. And when we think about the blood test, it becomes a rich source of data, both for mutation, chromosome rearrangement, copy numbers, but now we add in methylation, and we can continue to add in things like DNA fragment, and then ultimately add in other non-genomic methylation-based and virus sequences start to become a factor, as well as then immune typing. So we eventually now have the ability to personalize people's therapy, personalize their journey through cancer with a comprehensive longitudinal assessment of the tumor and even of the body at whole through epigenomics and immune response. So one can imagine when you start to piece all this information together, and here's a very nice paper looking at approximately 20,000 people and starting to look at specific genomic alterations with methylation and how it targets particular organs. And you can see once we start to think about all the different genomic changes and start to map out all the different tumors, you can see here that the purple is lung adenocarcinoma on the left, colorectal cancer, In the middle, you've got prostate, in the orange, breast in the pink, pancreas, and so forth. You can now start to map out not just the genomic piece, but also where the cancers are locating, migrating, and metastasizing to really start to bring together the diagnostic test and the journey for the patient. Although this brings up one particular challenge that we face, and that is data and information. It's important to realize that as we piece all this together, we ultimately need to understand what the outcome of the patient is based on that diagnostic test. And the more we have information on the diagnostic approach, the more it's important as we group people into these different diagnostic categories to personalize their approach, we need to understand the outcomes of these different groups. And so that really leads to how do we move forward in an environment where we need to understand the outcomes as these different groups and different diagnostics come to play. So one of the things we're also focused here at Guardant is collaborating and working with many different institutes and experts in the field and researchers to look at how we actually continue to build data. And so we're looking at growing our data through our research and collaboration. And here's an illustrative example of the volume we're expecting to grow in Guardant for the data and the genomics and epigenomics over different cancers. Once you start to link this with outcomes through various other databases, either through collaboration with research institutions or through various claims data and other public databases, we can actually start to now piece together a diagnostic approach that leads to a more personalized medicine interaction. And here's an example of how that comes to fruition. So this is using our database and taking the utility of ctDNA kinetics in advanced colorectal cancer. And again, this is just an example of how you start to piece together a personalized medical journey. So imagine now you could have somebody who has colorectal cancer. You start to monitor their response through molecular testing, and very quickly you can start to describe their journey. Are they in the orange or in the blue based on their initial responder measurements and kinetics? The main message here is by using evidence and data, having a test that measures kinetics is only as good as the outcome. And this really helps us understand what the outcomes are very, very quickly as we get more and more personalized and more groups and signatures. So really that brings me to how we're overcoming the barriers and how to get a high definition picture of molecular and cellular state. However, what does the future look like as we start to think about the diagnostic landscape for personalized medicine? And are we at the crossroads before symptoms develop to start to think about the molecular state? And someone could envisage here that as we're working towards understanding the genomics and the epigenomics, you start to produce a single state at any point in time in a person's disease journey. So for example, we can start with blood or tissue. I've already mentioned how blood is more convenient for journey, but tissue allows a different accuracy and even different additional testing and biomarkers. And then you can start to, through one single tube of blood or one single tissue test, start to go down and get nearly 750 different genes as we are today. You get amplifications, but importantly, you start to move into large rearrangements. You get tumor mutational burden, you get the methylome, the epigenomics, you get virus detection. And effectively, this test is something that we're rolling out now, and it's ready for patients to be using and for physicians and researchers to be using to really start to provide a comprehensive view of the patient. And then you can go one step further in the future and start to think about, as we're looking at the genomic features from the blood in the middle, and as I mentioned, the current state, which is the dark blue, you start to move into the epigenetic features, which I've highlighted some of the early data, and we move into that. And then ultimately we can move further into the microenvironment. And we're already starting to explore some of those places. And I've mentioned about plasticity, but we've also, of course, continue to look at immune cells, microvesicles, and so forth, and viromes and so forth. So the future for personalized medicine and diagnostics is certainly expanding. And again, we have to think about, as we get these groups and personalize through diagnostics, What is the outcome and how do we link that with data to better inform a personalized medicine approach? So ultimately, the future we see is envisaged like this. You have patient care with more than potentially 1 million people going through various forms of cancer screening and testing. We have the important work that we're all doing, which is research around how to understand these biomarkers, how to understand the testing and the outcomes. And really it becomes a mixture of the real world data, clinical use, discovery and characterization, as well as clinical development for therapies and treatments. And certainly at Guardant, this is one of the areas that we're focusing on, is how do we bring this platform of epigenomics, genomics, and real-world data and share that with the community at large to better understand the personalized journey for patients. However, the future doesn't end there, because when we start to think about genetic mutations and somatic mutations, we think about cancer. Most other diseases do not have this somatic mutation, but they do have genomic plasticity, particularly in the immune system and the microenvironment. They do show epigenomic changes and responses. So as now we start to think about personalized medicine, for the first time, we can really start to explore personalized medicine at the molecular level and the cellular state into other diseases, whether it be neurodegenerative, cardiovascular, autoimmune diseases like rheumatoid arthritis, inflammatory bowel disease. And so we are at the tipping point of bringing this information into other disease areas to truly make a molecular personalized journey possible. With that, I want to thank you for your attention, and I'll open it up for questions.
Thank you so much, Craig, for sharing your research with us today. Before we start the Q&A segment of this session, I just want to take a quick moment to remind our viewers to submit any questions they may have for Craig using the chat system to the right. And we do have time for a couple, so I'm going to start with one we've got in already, and that's, how does a liquid biopsy work?
Yeah, that's a great question. So all cells undergo cell cycle, which includes senescence. As they senesce and as cells undergo different forms of cell death, whether it be apoptosis, necrosis, and so forth, their DNA is shed into the bloodstream. And so these fragments of DNA, particularly wrapped around proteins like nucleosomes, circulate in the bloodstream. So by isolating these fragments of DNA and then performing various molecular testing, next generation sequencing, etc., you can start to assess and read these fragments of DNA and start to put the map together in different states. And so really a liquid biopsy is sampling the breakdown products from the cells and the tissue at hand. What makes it unique in cancer is with these somatic mutations, they become uniquely identifiable to that cancer. And so you can pick these up in the blood.
Lovely, thank you. Another question that we've got here is, what role does diagnostics play in precision oncology?
So one would argue that diagnostic medicine has been really around since Hippocrates. And so just think about it for a moment. A person who's diagnosed with a cancer is a diagnostic personalized journey. And as I mentioned, what we're trying to do is group people together who have similar features. And given that cancer is a molecular disease, it is a mutation at the molecular level, the expression of that molecular disease becomes critical, that we group people together to better ascertain their prognostic future, ascertain the impact of different treatments and therapies, all with a strive of improving the outcome for each individual patient. And so it plays a critical role, diagnostics, in trying to get people to group together so we can better understand the disease prognosis and therefore how to intervene and allow people to live longer with their cancer.
Excellent, thank you. And I think we've got time for one more quick one here. So what advancements have there been in liquid biopsies?
So the main advancement, if we think about liquid biopsy, is on several fronts. First and foremost, only 10 years ago, we started to think about genomic testing in the blood for cancer and it becoming mainstream. Then you follow on, you think about the advances of monitoring that disease over time through a blood test, and I shared some of the data on molecular response. Probably the advances moving forward, as I mentioned, are going to be looking at the epigenomic or functional state. RNA, of course, is in there as well, although it has challenges with blood testing in terms of consistency and stability of RNA. But more importantly, the future is actually starting to combine information, whether it be through understanding epigenetically the immune system, the different immune cells and how they respond to immune therapy, the interactions of the microenvironment with tissue-based epigenomic phenomena. I gave an example of cardiac toxicity, but think about the angiogenesis environment, then with the cell itself. So this is a really exciting future, and I believe a future that's going to rapidly expand our understanding of the personalized approach to cancer.
Lovely. Thank you so much, Craig. Unfortunately, that's all that we have time for today. So remember, like all previous talks, this presentation will be available for on-demand viewing for the next 30 days. That just leaves me to say thank you again so much, Craig. And for everyone watching, we'll be back tomorrow at 8 a.m. Pacific for another fantastic lineup of talks. Bye.